Okay, good morning, good afternoon, good evening all. A very warm welcome on behalf of the IPB events team. We're very much looking forward to supporting you with today's Advocacy to Action workshop, Evidence-Based Advocacy. And I'm now delighted to hand over to Jude to welcome you to the workshop. Thank you.
Thanks, Debs, and welcome everybody to our Advocacy to Action workshop, our first workshop in the learning series and the second event that we have had. I'd like to welcome you this evening, or whatever time it is for you. It's wonderful to see that we have people from all around the world, and it was also wonderful to see some of the benefits in the virtual working, in that connecting with people and being able to meet people in a more flexible arrangement. And I think that this workshop is one of the benefits of that, where we would normally have done things face to face. We really are looking to do things in different ways and formats as we all got used to the virtual world. I'm coming to you from Sydney, Australia, the land of the Gadigal people, and I'd just like to begin by acknowledging the traditional custodians of the land on which we meet today, and pay my respects to elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. And that is a familiar opening that we use in Australia to acknowledge the ownership of our land. So today's workshop is very, very much about sharing experiences so that we can learn together to amplify and scale up to provide eye care for that 1.1 billion people that have vision loss, mostly due to lack of access to services, and also to make sure that we make services sustainable for all going forward. So today we plan to sort of go through having a look at the variety of sources that can be used for evidence, understanding what those sources are and where we would put them into advocacy, considering what evidence you would use and when, and showcasing some key sources of evidence in the sector at the moment. The workshop schedule is, we have quite a busy schedule. Just move that on, yep. And it's a mixture of speakers and time where we can workshop things out together. We'll be hearing from Rupert Bourne from the Vision Loss Expert Group, Matthew Burton from the International Centre for Eye Health, Melissa Gong-Mitchell from the Global Coalition on Ageing, and Duratal Ayn Hassan from the World Council of Optometry. And I'll introduce our facilitators shortly, but we have the sessions facilitated by our wonderful IAPB facilitators. So just to get started, we'd like to just have a look first at the definition of advocacy. Advocacy can be and is defined in many different ways by many different organisations, but at its base, it's the process of influencing people and institutions in order to achieve a specific outcome. And in this Advocacy to Action series, we're really focusing on advocacy that focuses on policy change or practice change, so that the practice change is so that policies can be implemented, because policy change on its own actually won't achieve very much. So just wanted to set the scene to make sure we're all on the same page. And in the same light, where does evidence fit with advocacy? And so really, to be able to successfully bring change and have governments and all the stakeholders adopt and implement policies, we need compelling evidence to persuade decision makers why change is not just necessary, but beneficial. So we need to look at having evidence about what the problem is, who does the problem affect, why is it a problem, how can we address the problem, and what are the benefits of addressing the problem, or perhaps the consequences of not addressing the problem. So evidence needs to be, evidence is entwined in the advocacy process the whole way, from creating the case to the solutions to monitoring how the solutions are going, and creating new advocacy beyond that. I'd just like to take a moment to pay tribute to a good friend and colleague that we lost yesterday. And this session is really connects me to Hassan in many ways. Hassan Minto was a great advocate for eye health, optometry, for child eye health, and for low vision services. And it was Hassan who first worked with me to work out how to teach people on how to to teach people about advocacy and how to run advocacy. And also Hassan was a key leader in our school eye health advocacy and evidence creation for IAPB. And so I'd just like to pay my respect to him at this point in time and present some of his work done by many others as well, but it was appropriate today to talk about it in this context. So I'd like to just talk quickly through an example of using evidence in advocacy and, the layers of evidence that can be used and exist. So I'd like to look at child eye health. We know from the latest vision loss expert group data that around 90 million children live with vision loss. That's a pretty big problem. It's a global problem. It's global evidence. But if we want to present a compelling case to governments or other institutions to address this, we need to have more information than just a number of who it affects. So we have evidence at the moment about, thanks to the Lancet Global Commission for Eye Health, which Matthew will speak about later, bringing together many different studies which show us the outcomes of providing vision correction for children when they're at school. Now, whilst it might seem obvious that children will do better with a pair of glasses at school, it's something that evidence has been required for, and when there is concrete evidence, it is more widely accepted. And it's important that we often collect evidence as we go when we're implementing eye care services, but often we relate our evidence to the outputs, the number of services, the number of people seen, the number of glasses dispensed, the number of cataract surgeries done. And it's really important that as part of our evidence, we think about the outcomes. And it's much more stronger in the case of advocacy to be saying glasses can reduce the odds of failing a class by 44% rather than saying we can reach X million children. Then the next layer of evidence around school eye health is what can we do and what do we know about implementing solutions for children. And school eye health is one example of that, where we have been compiling evidence over a number of years, and Hassan has been critically involved in this area, and taking many case studies where IAPB members and other organisations have been implementing school eye health programs and putting that into a systematic review that was published in the WHO bulletin, so that it's given credibility, a global stance, yet it has much local knowledge in it that people can apply in different places around the world. And just the last layer of evidence that I sort of want to add to that in this is the professional evidence. And often, as a sector, we have to start together and decide, one clicker. We have to decide which is the evidence that we want to present together so that we can go collectively with one voice to governments or other institutions as relevant, and developing tools and communication tools for the sector to work with is really pivotal in linking evidence to advocacy. Two such examples that we have around school eye health is the school eye health guidelines that were developed by the School Eye Health Working Group in IAPB, which was chaired by Hassan. And also the Community Eye Health Journal is a wonderful resource for evidence that is often localised and has the professional aspects of evidence in it as well. So it's really critical that when we're thinking about what evidence to use in advocacy, and we can get it from a range of sources, we really want the evidence to be credible. So we know where it's from, we know what the methodology was used, we know how robust that was, and we present it accordingly, that it's verifiable. It's often strongest when it's in alliances, and you'll see from the presentations tonight that all of the evidence being presented has been done in alliances or partnerships or collaborations. And very importantly, it needs to be presented in a way that is appropriate to the audience that will be receiving it. So it is our job often to be the intermediary from taking the evidence from journals or tools like the Vision Atlas and presenting it as needed for that particular stakeholder. I'd like to introduce first up Rupert Bourne, who needs very little introduction, as the head of the Vision Loss Expert Group. And most people on this call, I'm sure, are familiar with the VLEG evidence. And I just thought I'd pop in the slide to just demonstrate the real impact that the evidence has, that VLEG has generated, from the papers through to populating the Vision Atlas, which is a tool very often used for advocacy, to being the underpinning data in the World Report on Vision and many other important documents and publications. Rupert is a professor of ophthalmology at Anglia Ruskin University, Cambridge, and consultant ophthalmic surgeon at Cambridge University Hospital, where he directs the Cambridge Eye Research Centre. Not surprisingly, he has a very long list of accolades and groups that he's involved in, but of particular interest to us is his involvement with overseas ophthalmology and design and analysis of several population-based studies of eye disease, several national in scope, such as Pakistan, Bangladesh and Trinidad. He's the chair of the National Institute for Health Research Ophthalmology Specialty Group, responsible for NHS research delivery. And in his role as coordinator of the Vision Loss Expert Group of the Global Burden of Disease Study, he has overseen long-term research into the worldwide prevalence rates of blindness and vision impairment in partnership with the WHO. So Rupert's been a wonderful partner in crime with the Vision Atlas, and it's been my privilege to be working with him over the last 12 months. So thank you for joining us this morning, Rupert.
So yeah, I've just been introduced. Thank you for that, Jude, and thank you very much to the IAPB for such an excellent event. It's great to see this sort of data receiving the sort of publicity and dissemination that these sorts of workshops can bring. So I'm very grateful to you for asking me to speak. I'm speaking on behalf of the Vision Loss Expert Group, and I'll explain to you in a moment as to who they are. And I've been coordinating this group since 2007 when it first started. I don't have any relevant financial disclosures. Next slide, please. So for the last 13 years, there's been this international collaboration of now more than 100 ophthalmic epidemiologists, and most of them are ophthalmologists and some optometrists as well involved. And most of these individuals are principal investigators, i.e. the people who put together big population-based eye surveys from around the world. So we've had a long-standing international collaboration. We're very grateful to the sponsors of the current 5-year cycle, who are listed here. And we work closely with the World Health Organization, for example, providing the data for the 2015 World Report on Vision, also with the Global Burden of Disease Study and the IAPB. Next slide, please. So here at the top left is Bill Gates talking at the 20th anniversary of the Global Burden of Disease Study, which took place a few years ago. Now, Bill Gates uses a term called actionable data, and I think it's great. It describes exactly what we want to try and achieve. It's all very well collecting data on numbers of people who are affected by vision impairment or blindness and by cause, and other factors associated with it. But if we're not unable to actually action that data, then it's really it's not a useful enterprise. So actionable data is something that we very much believe in within the Vision Loss Expert Group. And we've done many efforts to disseminate this data. This, for example, is an installation we put in at a big global eye research conference called ARVO, which actually is happening this week. We put this in a couple of years ago, showing how from a geographic perspective, how vision loss is changing over time. Next slide, please. So I'm going to talk to you a bit about what we do as the Vision Loss Expert Group, the Global Vision Database, which is the database that we curate, the Global Burden of Disease Study, because you'll hear a bit about that, and also the global epidemiological transition. So that's a big issue in terms of non-communicable diseases, such as, which is really the case with most of our eye diseases. The prevalence of vision loss in 2020, so just give you a flavour of the data that has come from the Vision Loss Expert Group and the GBD working together, how to access the data, and then some of the Vision Loss Expert Group outputs in the next 3 years. Next slide, please. Our goal is to develop and deploy new and improved evidence on the prevalence of blindness and vision impairment and its causes, on the intervention coverage, and to inform and influence global priorities and programs. So before the Vision Loss Expert Group started, the WHO would release infrequent updates on blindness and vision impairment prevalence from some published papers, but not through a formal systematic review. And there was very little disaggregation of the data, and it was really not possible to look meaningfully for change over time. There was no central, continuously updated database. With the advent of the Vision Loss Expert Group, in 2010, we published the first major outputs for vision impairment and blindness prevalence. And we've done that successfully for every 5 years. And what we have now is a global vision database, which is consists of 528 data sources. Multiple studies have offered us microdata, which we use, and there's a much more sophisticated statistical modeling of prevalence estimates than was possible before. We can also look at risk factors for blindness and vision impairment, which we couldn't do. Next slide, please. So what we do is we do a systematic review of all the published and many unpublished eye surveys from 1980 to the present day. We check these very carefully for population representativeness and quality in terms of things like clarity of methodology. And we also accept microdata from chief investigators. That all goes into the global vision database, and we analyze that and produce prevalence estimates. We then supply that data to the global burden of disease study. We've done that in this instance for the 2020 round. And what they do is they apply a disability weight to that prevalence, and that enables them to calculate disability adjusted life years, or DALYs. The next slide, please. The data in the Global Vision Database consists now of 528 population-based studies, so that's many, many millions of eye examinations. 46% of the sources are from rapid assessment studies, and since 2015, we've added a further 245 studies. So the database is disaggregated along various lines, but particularly along sex and cause-specific lines. Next slide, please. And the data sources, there are comprehensive studies, and then you've got rapid studies. So the comprehensive studies generally fairly well spread, fewer in low and in middle income countries, but there's data sparsity, particularly in Central Eastern Europe, Latin America and the Caribbean, and high income countries. Next slide, please. The rapid studies, which contribute just under half the data sources, as you'd expect, come from low and middle income countries. Next slide, please. I mentioned disability adjusted life years because they're the sort of the currency of measuring disease burden, disability worldwide. And next slide, please. What they do with the Global Burden of Disease study is they apply a disability weight to various states of health. And this disability weight can be anything from 0, which is a state equivalent to perfect health, to 1, which is a state equivalent to being dead. For the GBD 2020 series, blindness is just under 0.2 on that scale. And we feel actually that really is very much underrated. For the WHO, it's been increased more recently to about 0.4. But the downgrading of the disability weight for blindness does have considerable consequences, as you can imagine. Next slide, please. And this is the ranking in 2019, which is the latest GBD output of blindness and vision loss. On the left-hand side, you can see for 1990. On the right, in the middle, you can see for 2019. And you can see age-related hearing loss is rated at number 9 in those aged 50 to 74, and blindness and vision loss is ranked 19th. in 2019 for leading causes. So blindness and vision loss and hearing loss are high up the ranking. They're in the top 25 of the rankings of all diseases worldwide. Next slide, please. And what I've done here is I've just pulled the blindness and vision impairment data and the hearing loss data. And if you look at that for the 50 to 74-year-old group, so you look at the ranking of those combined, i.e. sensory loss, in grey here, it ranks 6th of all diseases. And for 75 plus, it ranks 5th. So if you're a government or a non-governmental organization where you take the DALI rankings of disease burden seriously and you are allocating resource according to the rankings, then actually sensory loss in the 75 plus year old group is actually higher in the rankings in terms of DALIs than diabetes, despite the relatively low disability weight associated with blindness and vision loss. Next slide, please. Countries are anywhere along this, what's called the epidemiological transition. And these are 3 slides, 3 images of the whole healthcare burden within each of these 3 countries, going from Nigeria on the left-hand side to Germany on the right. I've just selected 3 countries. But the blue part of the box is the non-communicable disease. And you can see that as countries move along this transition, this development scale, the non-communicable diseases become more and more important, and they squeeze out the maternal, neonatal, and childhood and communicable diseases, which of course are partly responsible for the eye disease burden, but generally most of our eye disease fits within the non-communicable burden, which is the blue area. So we're seeing this transition across countries over time. Next slide, please. We've published this data. You can access this for free from these links. This was published in February this year. These are the 2 papers in the Lancet Global Health. And we supplied this data to the Lancet Global Commission, which was completed in February. Next slide, please. And in terms of numbers of people blind, we estimate 43 million people blind in 2020, 257 million with mild vision impairment, and 295 million with moderate and severe vision impairment. And 507 million people are near vision impaired. Next slide, please. And you can see by cause, cataract is very important, particularly for numbers of people blind. It's the highest, biggest contributor to blindness worldwide. But uncorrected refractive error is the big contributor to moderate and severe vision impairment. And smaller contributions, although still very substantial, from age-related macular degeneration, glaucoma, and diabetic retinopathy, which are featured here. You can find this all in the Lancet Global Health papers and also in Vision Atlas. Next slide, please. I wanted to show change, and in this slide we can see with the purple parts of the graph, that's for blindness, and it's showing the change between 1990 to 2020, so over 30 years. It's showing a reduction in the age standardized prevalence of blindness for all causes listed here, except for diabetic retinopathy, where the age standardized prevalence of blindness due to diabetic retinopathy is on the increase. So that's unusual compared to the other causes. Next slide, please. In terms of the sex differences, there are inequalities for those major causes, and for global blindness, females are more likely to be affected by blindness, except for glaucoma, where it's the other way around. Next slide, please. So the prevalence is falling, the age standardized prevalence is falling, but the numbers are rising. And this sketch from the Alice in Wonderland series of Alice running with a red queen is a great sort of example of the problem, where she's running as fast as she can. We're all running as fast as we can, but we don't seem to be getting anywhere in terms of the landscape moving and the numbers of cases continuing to increase over time, despite the age standardized prevalence reducing. Next slide. And this really explains it. Here we've decomposed the numbers of cases of blindness that have increased over time, and we've over 30 years. And that's because of changes in the population growth, but also the changes in age structure of the population. So what this is showing is that had we not intervened, had there been no interventions over that period of time, we'd anticipate an extra 16 million people being blind if we'd gone on just the 1990 figures. So our interventions, plus a lot of other factors, are making a difference. And that's a really important advocacy message. Next slide, please. We're very pleased to work closely with the IAPB. We have an arrangement between the Vision Loss Expert Group and the IAPB where we've provided the data for Vision Atlas, and that was launched in 2017, and a major update took place recently. And here you can access the data through maps, next slide, which allow you to pull data and filter it according to gender, for example, the condition and the year. And this is really exciting. For me, this really is just a wonderful tool. It means that any internet user anywhere in the world can draw down data. They can use it to make a case for change within their country. So there is data for every country across different years and by sex as well. Next slide, please. So in terms of our ongoing work, we've added a further 200 data sources just recently, and more data. As you saw earlier, we produced the data for the World Report on Vision, and we work closely with the WHO. We provide global, region and country data and forecasts to multiple users listed here, not just WHO, but the GBD, European Coalition for Vision, and governments. And also through the visualizations with Vision Atlas, with the IAPB, that's another way of disseminating the data. We've done a lot of work on driving improvements and consensus on design and reporting of population-based eye surveys. And we have active work looking at risk factors and the risk associated with blindness and vision impairment. And also there are a lot of allied epidemiological fields such as hearing loss, healthy aging and diabetes, who we're working closely with too, because looking within rather than necessarily between countries is just as important. Next slide, please. So thank you very much. If you want any further information, please don't hesitate to contact us. And I do want to thank our sponsors of the Vision Loss Expert Group's work. Thank you.
Thanks, Rupert. Thank you for explaining and unpacking how important the work is of the Vision Loss Expert Group, both in comparing it to the GBD model, or using the GBD model and other GBD ranked conditions, and so giving us a perspective on eye health that is outside the eye health sector. And I think that's really important and shows us opportunities for advocacy or connection or collaboration, like you suggested with the hearing loss and into the sensory bracket. And we will go and explore some of that data in the workshop coming up. Now, we are quite behind on time, so I'm going to put a challenge out to our next speakers to keep it concise on time. And I'm going to introduce, without further ado, Matthew Burton from the International Centre for Eye Health and the co-chair of the Lancet Global Health Commission for Global Eye Health. It's a mouthful of a word, but it's a great, amazing achievement. Congratulations. And I also just wanted to highlight, the links between pulling together a commission as large as what Matthew did, with many systematic reviews, original research and expert consensus, as well as case studies and local type of evidence. And it's already generating many fantastic tools, such as the one on the right, where just summarising the SDG messages that are in there. So welcome, Matthew, and it's really a pleasure to have you here with us today.
Great. Thank you, Jude. And thank you to everyone else who's here on this meeting, this webinar, for the opportunity to talk to you today about some of the findings from the Lancet Commission that we think are probably most relevant to advocacy. As you all know, this is a pivotal time for eye health. Last year was the culmination of the Global Initiative Vision 2020. In 2019, WHO published the World Report on Vision. And in 2020, the World Health Assembly passed a resolution on vision. The Commission report is the work of an interdisciplinary group of 73 academics, national program leaders and practitioners from 25 countries. A further 75 people contributed to many of the reviews that you just mentioned, which are being published as subsidiary papers. The Commission report and its appendices, which are quite extensive, can be accessed on the website or through the Lancet Global Health website itself. You can get the link at the bottom there. In addition to the main report and appendices, the Commission website also holds the subsidiary publications, lots of case studies from all around the world and other resources and podcasts and so on. So there's lots of material there to dive into and get more resources. We explore eye health from a number of different perspectives, but for the purposes of our meeting today, there are probably three main sections that are most relevant. The one, section 2 on the importance of eye health, section 3 on the magnitude, and section 4 on the economics. We examined the importance of eye health from several perspectives, including its impact on quality of life, general health, well-being, and mortality. But our starting point, and possibly the most important point to get across here, was an investigation of the relationship between improving eye health and the impact of this on the Sustainable Development Goals. As part of the Commission, we conducted a rigorous scoping review which systematically searched the published and grey literature for studies investigating how improving eye health can contribute to advancing the SDGs. In all, we identified 29 studies that met the criteria that reported direct benefits from providing eye health services on SDGs. And this table from the report organizes that evidence. And if you're interested in learning more, I'd encourage you to have a look at this. The main paper that sits under this, it will hopefully be coming out in the next month or so. Briefly, we found evidence that the provision of eye care services is associated with improvements in workplace and economic productivity, household consumption, and income and employment. The resulting economic benefits, particularly when delivered in resource-limited settings, can contribute to advancing the SDGs on poverty reduction, number 1, food security, number 2, and decent work, number 8. For example, a trial from India showed that the provision of free spectacles to tea workers with near vision impairment improved workplace productivity by around 22%. Educational performance is linked to vision. Children with vision impairment have poorer educational outcomes and are more likely to be excluded from schools. And there are several randomized controlled trials that have found that providing spectacles to school-age children improves educational performance, supporting quality education, SDG 4. And of course, improved educational outcomes is crucial to development, reducing poverty and hunger and enabling work, SDGs 1, 2, and 8. Women carry a greater proportion of vision impairment than men. Addressing vision impairment, improving eye health is relevant to both gender equality and reducing inequalities in general. A study from Kenya, Bangladesh, and the Philippines found that people with vision impairment from cataract were poorer and reported a lower quality of life than their neighbors who didn't have cataract. 1 year after surgery, this gap was gone with no difference in markers of poverty, such as household expenditure. SDG 3 and SDG 11 include targets to reduce road traffic injuries, a leading cause of death in children and young adults. Multiple studies report associations between some eye conditions and motor vehicle collisions, whereas cataract surgery leads to a reduced driving difficulties and fewer collisions. Responsible consumption. So globally, eye healthcare contributes around 5% of greenhouse gas emissions, and eye health as a high volume service within healthcare is probably a significant contributor to this. The Commission found limited research at this stage on environmental impact of eye health care service delivery. However, there are practices that vary, leading to differences in the levels of environmental impact, such as, for example, the rubbish produced by a cataract operation in the UK being substantially more than that in India. So in summary, we found multiple studies that provide diverse evidence that action to improve eye health, reducing vision impairment, can result in a positive impact on multiple SDGs. In this diagram, the solid green arrows radiating out from improved eye health indicate direct effects for which there's direct evidence, and the black arrows, indirect benefits. Our overall conclusion is that improving eye health and reducing vision impairment is important, if not essential, as an enabler for achieving the SDGs. This is a really crucial advocacy message. Impaired vision and eye health have a broad impact on general health and well-being, so SDG 3. And in a series of reviews and analyses in the Commission, we mapped out the complex connections between eye health and general health. Specifically, impaired health has widespread direct impact, for example, on exacerbating depression and dementia, increasing cardiovascular disease risk through reduced physical activity, increased injuries, and reduced access to healthcare. Vision impairment and eye health are often perceived to have little effect on mortality. The Commission conducted a systematic review and meta-analysis, the references at the bottom, of the relationship between different levels of vision impairment and subsequent risk of mortality. And we found clear evidence that increased mortality risk with increasing severity of vision impairment. Reliable data on the magnitude of vision impairment and eye disease is crucially important in making the advocacy case. And we've just heard from Rupert in detail about the recent work published by the Vision Loss Expert Group in the Global Burden of Disease study for vision impairment in 2020, and the references at the bottom. And you can also read a summary of this work prepared by Rupert for the Commission in the report. These graphs show the global trend in the estimated number of people with vision impairment from 1990 to 2050 from the VLEG study. Despite work to scale up health services around the world, the numbers affected are forecast to rise substantially as need outstrips supply. These increases are in large part driven by aging of the world population alongside growth of the world population. And by 2050, it's estimated that there could be as many as 1.8 billion people with unaddressed vision impairment. So this is a really critically important advocacy message to get across. The health economic case is also really important in advocacy, and the Commission analysed several aspects of the economics of eye health, including a systematic review of the literature, a fresh analysis of the productivity loss associated with it, and cost effectiveness of a couple of interventions. We developed a new estimation using the latest available data for the annual global and regional economic productivity losses attributable to vision impairment. This is based on the product of the number of people with blindness and moderate and severe vision impairment in the working age population, employment to population ratios, the relative reduction in employment, and the gross domestic product per capita. Globally, this came to around $411 billion per year, with the East Asian region having the greatest productivity losses. We also updated the cost effectiveness analyses for cataract surgery and refractive error services, which account together for around 90% of unmet need globally. The good news is that both of these are highly cost-effective interventions. These plots from the Commission report give you a sense of the cost effectiveness of both cataract surgery and refractive error services for different world regions. So in the Commission, there are 10 key messages in the summary. The most important of these can be found on the front cover. Investing in universal health is a realistic, eye health is a realistic, cost-effective way of unlocking human potential by improving health and well-being, education, work, and the economy. It's essential to achieving the Sustainable Development Goals. So in summary, the Commission seeks to reframe eye health not only as a matter of health, but as an enabling, cross-cutting issue within the Sustainable Development Framework. And we believe the evidence in favour of urgent action globally is really compelling. I encourage you to read the report if you haven't done so already, and please do explore the website for the growing collection of additional resources you'll find there. Thanks very much for your attention. Back to you, Jude.
Thanks, Matthew. That was a really wonderful, clear explanation of so much complex information that is presented in the Commission. It's really wonderful to have it in simplified messages and visuals that can be used. I really liked your eye chart diagram with a number of people that were visually impaired. And that's quite impactful. I'm now delighted to introduce Melissa Gong-Mitchell from the Global Coalition for Ageing. It's wonderful to have Melissa here today to be from a outside of the eye health sector point of view, and to share with us the incredible work they do there, including the International Vision Health Scorecard, which you can also find on the Vision Atlas and obviously on the GCOA site. Melissa is the Executive Director of the Global Coalition on Ageing, the leading business voice on ageing policy and strategy. In her role with GCOA, Melissa is responsible for the operations and management of the coalition, internal and external communication strategies, and member and stakeholder outreach and development, including fostering relationships and aligning partners across the industry and all areas of the sector. That's quite a role, Melissa. Welcome, and thank you for joining us. We hope to learn a lot from all those amazing responsibilities that you have and do so well at the GCOA.
Thank you so much, Jude. I really appreciate the opportunity to speak to you all today. And we were just talking about in our group about how do you create urgency with the advocacy messages. And I've been working in this space for a long time, looking at healthy aging, and healthy vision is an important piece of that. But for my entire 20-year career, I've really been focused on advocacy. So how do we take this wonderful evidence and data that is coming from Matthew and coming from Rupert and coming from IAPB, and how do we turn that into actual action? So I'm really excited to be here and to have been partnered with IAPB for a while now. So just a quick background on who we are. The Global Coalition on Aging is a business group, a business consortium, and we partner with other global leaders. And that's a really important message around advocacy too, is understanding who you're going to be partnering with. Who are you going to be relying on in addition to you to be able to echo the messages that you are creating in the advocacy narrative that you are wanting to communicate. So we've developed this network over time to recognize the connection between healthy aging and so many issues related to health, financial health, physical health, mental health, etc. And so that network is really critical in how you develop evidence and how you make it effective. So we've really looked at vision health by focusing on three main really messages, and that we recognize that aging is a global mega trend. We've heard that multiple times in today's workshop, but that's really a first key message, is that this connection between aging and the health of overall society is something that isn't enough addressed by global policymakers, but we are seeing evidence that is moving forward. So in areas including Alzheimer's, heart failure and cardiovascular disease, osteoporosis, eye health, we need to do more. And we do that through the lens of the growing aging population. We feel like that does help create that urgency. The next message we've really been focused on from an eye health point of view, of course, there is this, this connection between healthy aging and healthy vision. And when you connect these global trends together, it brings stakeholders and advocates together. It brings evidence together from powerful arguments that are being created across these different stakeholder groups. We know that vision loss and vision deterioration in many ways is increasing because of the growing aging population, and that should be a lot to help policymakers understand the need and urgency. And then the third message that we've been looking at is, well, how do we create powerful messaging around these two global trends that are coming together? There is a connection between vision loss and it increases with aging, but there's also relevance in terms of individual, emotional, physical, and connection to one's eyesight. We've looked at various data that shows that, the vision is the most important, sense that people value. And so when you combine that with the fact that we are seeing a rise in vision loss and vision diseases as people age, that loss of control, that loss of independence becomes a very powerful message, because people can see that individually in their life as well. But what we're also seeing through the aging lens is that many times these very clear connections, and that is shown through the data that has been displayed here today, it's often disregarded because sometimes older people, and many times we're seeing older people, conditions that do increase with age are dismissed as normal parts of aging. But we all know here that 90% of that vision loss is preventable. So if we take action early, then we can make sure that no individual is left behind. We can ensure that people can maintain their independence for longer. That means they can maintain their productivity in society for longer. That benefits everyone. And that's an important message that policymakers can certainly understand. So also, as has been stated here already today during this workshop, the vision health community is really upon a major opportunity in global policy making. The global priorities on public health, the public health agenda led by the UN, WHO, and others. This is a really important place in terms of changing and increasing expert focus on and opinion when we're talking about effective advocacy. So these are the frameworks, as we have discussed, when you look at the connection to the Sustainable Development Goals, and I love the way that that is framed out in the Lancet report, and we look at the great data that's coming out of the World Vision Report, the Atlas, which becomes such a useful tool from IPB. These are really powerful. And then when you combine that with something like the Decade of Healthy Aging, which I'm not sure if everyone here is aware of, it's really, it gives us a really good platform. So the Decade of Healthy Aging was officially launched this year by the World Health Organization, and it was taken on by the UN as well. So the decade is 2021 to 2030. And the focus of the Decade of Healthy Aging is ensuring that when we look at health, it's not measured merely by the absence of disease, which of course is a very important metric, but also in the ability for a person to maintain their functional ability. So to ensure that they have the capabilities to do the things that they value and that they desire to do over the course of time and as they age. So it's about also that longer life, but really importantly, that quality of life, and ensuring that as we live longer, we're also living healthier. And that gives us a really strong platform to deliver some of these messages around the importance of vision health and eye care. So when you sort of combine this evidence that we've been discussing today with a lot of these global markers and what I call hooks, you want to find that hook that a policymaker would be really interested in, we have a really good place to start from. And so when we thought about the creation of the International Vision Health Scorecard, we asked ourselves, what do we know? What are the compelling data and stories? And what are the experts telling us? So we know that the data tells us one thing, but as we discussed in our groups, the experts tell us something else as well, because they're seeing what's happening in real time and they can validate the data by their own experiences as experts. And then of course, who do we want to influence? And we know when we talk about advocacy here, it says policymakers. So how can we ensure that we make, for the end game, how do we make sure that we make our messages powerful? And what are the messages around? We talked in our group about simplifying that ask. Can we create the messages that advocates can grasp onto and that advocates can drive forward? And a lot of times that really is about simplifying those messages. And then we want to ask ourselves, what actions will policymakers actually take? So when you go into any advocacy situation, it's about having that clear ask. And Jess said it's there's 3 bullet points. And we see that that's a standard throughout advocacy. So the role we play is to make sure we're developing those messages based on the evidence, based on the experts, to make sure that it does lead to action. So we want to make sure you get the International Vision Health Scorecard, because another thing that we did in working closely with IAPB and clearly a whole group of experts, and not only pulling together the evidence, but validating that evidence with the experts. And we also looked at this not from a global only perspective, but 15 countries. And one of the other ways that we've seen that advocacy works is when there's almost a comparison, because when we create something like the scorecard, we've done indexes for other health areas, that it almost makes governments look at each other and say, okay, why am I lagging behind in one area or the other? So we looked at six to seven major categories, including national strategy, prevention, and other issues, to make sure that we were looking at this from a global perspective, connecting aging and vision, but also looking at it from a country perspective. And again, about activating those networks. When we launched the Vision Health Scorecard, we wanted to make sure that we had vision health experts. We wanted to have aging experts as well. And we brought a whole large group of interested folks to that launch event. So just in closing, as you're thinking about combining the opportunities of global trends and seeing what the environment looks like in which you want to be giving your messages, we think it's really important to make sure, of course, we're showcasing that data and best practice and showing not only the crisis, but also the opportunity and how we message that. And then fostering collaboration, building out your network, and whether that's you all in the vision community working with us in the aging community or other spaces, that helps give you more stakeholders who are delivering your messages. And then, of course, you always want to call for a specific policy change and development of more research, because we can always use more messages and more evidence, even though there's such wonderful evidence here today. You're at a wonderful place in the vision health community. And then you want to think about, finally, what is that mechanism for monitoring progress? How do you hold decision makers accountable? And so you have to repeat. It's one of those things. You develop the messages, you take it to policymakers, but you have to keep doing it. So I know we're short on time, so I wanted to get those messages across rapidly. And thank you for your time, and thank you, IAPB, for hosting this wonderful workshop.
Thank you, Melissa. That was fantastic. It was so well thought out and integrated. And there's a couple of things that I really picked up and liked. The slide where you said vision is valued but rarely prioritised. I think it's a great message, and the data really supports that. And hopefully that's something we can monitor over the next strategy that's being implemented, and hopefully it will change in time. And I also really like your summary. Summarises a lot of what we want to talk about today. Is you be able to showcase the data, the good principles of using evidence, showcasing data, collaborations, calling for policy change, but also for further research, something that came out of both the VLEG studies, the Lancet studies, the scorecard, and almost anything is there, the need to find out more and to continue, and in particular monitoring and evaluating. And I was going to bring it up a bit later, but in our sector, WHO will be releasing the new indicators to measure, the success of eye health going forward and eye care services. And, it'd be really important that we need to advocate for the collection of those targets so that we can have the evidence for what happens next. So thank you for bringing all those points to the table. And as you said, we are short on time, so I'm going to move straight to the next speaker, which is Juratal, who is joining us from Malaysia, Juratal Ain Hussin, who is speaking on behalf of the World Council of Optometry. And after hearing about so much of the evidence, the new evidence that we have, we thought we would pull together an example of where evidence has been used in advocacy to successfully expand primary eye care services, which is a major goal of the WHO. So Juratal is a Senior Principal Assistant Director of the Allied Health Sciences Division at the Ministry of Health in Malaysia. She's an optometrist by profession and has worked in various public hospitals throughout Malaysia. So without further ado, I'd like to welcome Juratal.
Thank you, IAPB, for inviting me to talk at this platform. It is an honor for me to share with all of you about the advocacy work that we are doing in Malaysia, especially on the primary eye care services. Let me share the screen. So, good day, everyone. The topic is the advocacy for expansion of primary eye care service at public community health clinics in Malaysia. I must, however, give a statement that the opinions that I'm going to share tonight is of my own. It doesn't reflect the Ministry of Health Malaysia, except the fact that has been clearly sourced and referenced. So this is actually relevant to the date of current presentation. Set the scene to begin with. These are the two pie charts about the burden of eye diseases in Malaysia, the causes of blindness and low vision. For adults aged 50 years and older, the study from National Eye Survey 2014, the main cause of blindness is due to cataract up to 60%, followed by diabetic retinopathy for 10%, glaucoma 7%. This is actually consistent with other developing countries and our neighbors. For children aged 7 to 15 years old, we have an old data way back in 2005 through the refractive error in school children survey, which found that the main cause for low vision or visual impairment among the school children is refractive error, with myopia is most prevalent. And a number of children have been found to have amblyopia for 2% and unexplained of 10%, which presumed to have been caused by amblyopia as well. Our RESC study is actually due for another round next year, and hopefully after the COVID-19 ease, this will be conducted successfully. What do these two studies mean to Malaysia? There are three key messages, which is all those diseases are asymptomatic: cataracts, diabetic retinopathy, glaucoma, refractive error. All those patients or people only come to see an ophthalmologist only after they being affected in their daily living. So only through early detections and screening can make sure that they receive earlier treatment and surgery. For the children, it is a simple means of spectacles. Because of that, it is very important for us to improve our eye care and refractive care, which needs to be more accessible and affordable to the people. These findings are actually makes the importance of community eye-based primary eye care services in the country, consistent with the World Report on Vision, strengthening about the integrated people-centered eye care, which promotes the implementation of eye care within the community. There are actually 4 key strategies to achieve the integrated people-centered eye care, which around enabling the community, reorienting the model care towards primary care, to improve the community in the across and within sectors, collaborations, and also to improve the services as well within the community. Now, I'd like to zoom into the Malaysian Ministry of Health pyramid, especially on the eye care services. At the moment, most optometrists are actually positioned in the hospital with ophthalmologists, a few without ophthalmologist hospitals, and only 2 across the country who are working in the health or community clinics, which we know at this level, they are the ones who should be doing the preventions of blindness activities, promotive programs, detections of eye diseases, referrals to the ophthalmologists, and training to the health staff and rehabilitations. Because due to these, only a small numbers of optometrists at the health community clinics and hospitals without ophthalmologists. So the hospital with ophthalmologists, the ophthalmologists, optometrists, the eye care nurses are currently doing the outreach program on top of their current roles at the hospitals, which is for optometrists. There are pre and post refractions, diagnostic tests, preoperative procedures, and subspecialty optometry. So this is the work that we are doing. We want to add more optometrists at the health community clinics in order to make sure that the activities for the prevention of blindness is focused at primary care level. Now, after many years of working hard on the policy paper, which is about the expansions and strengthening of the optometry services at primary health, only on the 26th of January this year, our policy paper got accepted to be presented at the special meeting of the Director General of Health in the Ministry of Health Malaysia. This is actually the highest level of meeting among stakeholders throughout the country, with the participants or the attendees of the meetings are the directors of the health states across Malaysia, and chaired by the Tan Sri, or the Director General of Health himself. We are very, very glad and happy that on that date, our paper, the expansion policy paper, has been approved and passed this meeting, which is the significant milestone for us in Malaysia. However, this doesn't happen overnight. We have been working since 2011 until today, almost 10 years already, which involves lots of tough stakeholders, multiple levels, and lots of work, discussions, presentations, and we also make a training, credentialing, and we are fortunate to have our partners in the Association of the Malaysian Optometrists to work on campaigns and to advocate with the minister directly. But among all those activities, I think I must say that this is actually needs to be supported by strong evidence, which is the PhD study that I did with the supervised by Associate Professor Peter Handicott in 2013 up to 2016. So from these study findings, when I came back, I know that this actually needs to be used for the advocacy. First, we set up the ophthalmology and optometry committee for the primary eye care, which is the most important in the stakeholders' involvement. Now, let's zoom into the research findings and how this is used in the advocacy. We've got in the study about the diagnosis accuracy between the ophthalmologists and optometrists, which high concordance up to 87% match. And then we have the findings about the referral decisions to the ophthalmologists with a CAPA agreement of 0.76, with the optometrists being very cautious. They have classified more cases as urgent, very urgent, as non-urgent. And we have also data on the sensitivity and specificity of diabetic retinopathy screening, which needs to be polished up on the sensitivity, which is quite on the moderate side of percentage. We also have a triaging referrals from the primary care clinics to the ophthalmologists, which shows that the optometrist needs to also classify the cases that needs to be seen at their level instead of referring all to the ophthalmologist, as a result of being anxious about their being studied in the research that time. The study also includes a patient satisfaction survey, which overall the satisfactions are very good and outstanding because of accessibility is better and lower cost for these eye care services. Now, that's the summary of the research. And then we use these findings at each levels of our advocacy. For example, we tell the public system in the public healthcare system that when the optometrists are positioned at the primary care level, they can be able to practice more of their knowledge and skills that they have learned during their bachelor degree, and this can be a benefit in terms of improved outcomes to the eye care system. Indirectly, it will reduce the waiting times, allowing more timely investigations for the ophthalmology in order to detect the eye diseases, and also can offer treatment for the patients in a timely manner. And lastly, this allow better use of ophthalmology resources so that the ophthalmologists, the doctors can do more surgeries instead of screening. And lastly, the importance of including the partnership with the private sector, because we have more optometrists working in the private sectors as compared to the public sector. So we need to work with them in order for them to apply the primary eye care knowledge and services at their private setting. And instead of only focusing on refractive care. What do I want to stress as a conclusion for my presentation is whenever we want to do an advocacy, we need to supplement with evidence study. It could be best if you have your own study to support the advocacy. But if you don't, you can use other sources, lessons from other countries, for instance, and use this to be specific on each level of the stakeholders that you are dealing with, because you know that each of the stakeholder has their own interests, has their own governance that they need to maintain and to guard. And second thing is the importance to develop this public and private partnership. It is actually in other way makes the work more complicated, but that is the way forward, especially for Malaysia, because we know that the government alone cannot sustain this project, but it needs to be in a teamwork with the private sector as a partners. So with that, I think I'll end now. I'm happy to receive questions via email, and I hope this talk is beneficial for everyone that attends for today's advocacy session. Thank you so much for listening.
Thank you, Juritel. It was really useful to be stepped through the process that you've gone through with connecting evidence to advocacy, and again seeing that cycle, as Melissa pointed out before, where evidence advocacy on repeat. So just a quick summary around evidence needing to be credible, verifiable, built-in alliances, and to be presented appropriately to the right people. We have a variety of sources at a global, local and professional level, and there are gaps in the evidence, and there's a need to advocate for evidence itself. In particular, as I mentioned, the WHO targets. We really encourage everybody on this call to get involved and join working groups, IAPB working groups or other ones around generating evidence or creating messages from evidence or forming coalitions. There's a quick list there of sources that have been cited today. We will send those out to you after the email. And as you know, this is a 6-part series. So the next workshop will be in June, and it will be a webinar on Beyond Eyes, where we will look at integrating eyes into the Sustainable Development Goals. And you'll get an email shortly about the details of that and be able to sign up when that comes through on conclusion of this webinar. And just wanted to say a big thank you to everybody, and particularly to my colleagues, Jissa, Zoe, Jess and Holly for and Anthea for pulling all of this together, and to our wonderful speakers tonight, Matthew, Rupert, Melissa and Jurital. Thank you for all your participation.